I am delighted to be here today talking to you about a less delightful topic of financial toxicity. And as Lori mentioned, I work for an organization called Triage Cancer, and we really are dedicated to providing education on all of the legal and practical issues that come up after a cancer diagnosis. Because the reality is so many of the issues that do come up are rooted in the law. So financial toxicity, what is it? In 2013, researchers out of Duke coined this term, and in their research, they focused on this financial burden that comes up with a cancer diagnosis and how it is in fact quite similar to the physical burden that is tied to many cancer treatments. But what was particularly interesting about their research is they didn't just look at the dollars and cents of it all, but they really looked at how this financial toxicity or financial burden impacted treatment and outcomes and overall quality of life. So while it's certainly become the buzz term over the last couple of years, it is not a new problem. So why is it so hard to address this problem of financial toxicity? Well, the reality is there are multiple contributing factors. And certainly the cost of cancer treatment is a piece of that, but I would argue there are in fact much more significant factors, including somebody's health insurance status. Now, that might mean do they or don't they have health insurance, but oftentimes it means do they have the right health insurance for them? And then are they effectively using that policy? Certainly the employment changes that can come along with diagnosis, impact finance, and then the things finance in life continue to happen. So relationship changes, moving, graduating, all of those things can be a financial burden, and now we're compounding cancer treatment with it. So what do we do about it? This is a visualization of many of the questions that can be asked of people, regardless of where they are along the continuum of care, to start to try to address these factors. And I realize it is tiny and very hard to see, but there is a link at the bottom, and we're going to be putting a resource document with clickable links for you to see a full-size version of this. But what I want you to take away from this is these are a starting point. And when you go to that full-size version, you'll not only see these questions, but on the right-hand side, you're going to see all of the resources that we have to help you deal with the answers to those questions. Because it's not enough just to deal with the cost of treatment. We have to look at you as a whole person and what your life looks like and how this treatment is going to impact your life and then impact your finances. So I mentioned that health insurance status is the #1 contributing factor. And part of the problem with this is that understanding health insurance is like learning a new language, and yet no one's teaching that language. So if you feel like you don't have a totally great grasp on how health insurance works or how to pick the best plan, you are certainly not alone. So I'm going to go over some basics today. And again, it's going to be pretty quick, but know that we have resources and opportunities for you to learn more in depth at future dates. So there are 3 main places we get health insurance in this country. The largest number of Americans get their insurance through an employer. The next largest group get their insurance through a government program, primarily Medicare and Medicaid. And then the smallest number of Americans go directly to a health insurance company to buy their insurance. But regardless of where you fall in this triangle, there are some terms that you need to understand. So there are costs just to have health insurance, and that's your monthly premium. And you're going to pay it monthly, whether you go to the doctor or not. It's like having car insurance all year, but never getting into an accident and filing a claim. But then there are some other costs that you're going to incur once you actually try and use your health insurance. Every policy is going to have an annual deductible, and this is a fixed dollar amount that you have to pay each year before your health insurance company starts picking up their share of the costs. Their share of the cost is referred to as cost share. So you're literally sharing the cost, and this is a percentage. So maybe you have an 80-20 cost share. And what that means is that once you've met your deductible, your insurance company will pick up 80% of your costs, and you're responsible for 20%. Now, many policies also have an additional payment called a copayment. And this is, again, a fixed fixed dollar amount per service. You might have a plan that has a $25 copayment when you go and see the doctor, or a $250 copayment if you go to the ER. But I would argue that next to your premium, the most important thing for you to understand about your policy is your out-of-pocket maximum. Because in theory, this is as much as you're going to pay out of pocket in a worst case scenario. And the way you get to that out-of-pocket maximum is a math problem. So you add up everything you pay towards your deductible, everything you pay towards copayments, and everything you pay towards coinsurance to get to that out-of-pocket maximum. Now, of course, there are details, and some employer policies have a slightly different formula here, but this is a very general, pretty basic formula. And typically, they're only going to look at in-network services. So it is important to understand what providers are in the network of your plan. So to illustrate how all of this works, meet Dan. Dan has a policy with a $2,000 deductible. It's an 80/20 coinsurance, and it has an $8,000 out-of-pocket maximum. Dan gets into an accident and ends up with a $102,000 hospital bill. Assuming he hasn't had any other medical care for the year, how much does he have to pay? Well, the first thing we always start with is that deductible. So $2,000 off the bat, which leaves $100,000 of the bill. Well, 20% of $100,000 is $20,000. But because his plan has that out-of-pocket maximum, he's only responsible for paying another $6,000 to get to his $8,000 out-of-pocket maximum. Now, I am not suggesting that $8,000 isn't a lot of money. Of course it is. But when we stop and think about the alternatives of what he would have to pay without the out-of-pocket maximum, or even without insurance, it starts to feel a little more palatable. Now, if you want to hear any of that again, or think it might be useful for people you know to hear that, that's included in one of our animated videos in English and Spanish, and it does include closed captioning as well. Now, with Medicare, there's a lot of confusion because there's two main lanes that someone can choose from. The first lane is original Medicare, where you get hospital insurance through Part A, you get medical insurance through Part B, which is things like seeing the doctor and immunizations and scans. You get prescription drugs through Part D. And then because Part B doesn't have an out-of-pocket maximum, you can purchase an additional plan to help cover and protect you from those out-of-pocket maximums, referred to as Medigap plans. That's one lane. Lane 2 is what's referred to as an Advantage plan, or Part C. And these plans operate more like what we're used to with employer plans, where all of your services are typically bundled into one managed care plan with a smaller network of providers. Now, Lane 2 comes with an out-of-pocket maximum. Now, I realize that that is the 50,000-foot view of Medicare, but the basics here are that the very first decision that you have to make is, which lane are you going to drive in? And then there are some additional decisions after that. And of course, we have resources to help you understand those different decisions. Each year, there are specific times when we get to either pick up a new policy or make changes. And this is incredibly important because what we might have needed before a cancer diagnosis could be very different from what we need now. And we now have some freedom in that we can make choices each year so that the plan coming is going to better meet our needs. Now, typically, open enrollment for the marketplaces, which is what was created under the Affordable Care Act, or Obamacare, happens in the fall. But I have to tell you that we are in an unprecedented situation due to the pandemic, in that the president has reopened these marketplaces through August 15th and has increased the availability of financial assistance in these marketplaces. So if you are sitting there feeling like you don't have a policy that meets your needs and covers your doctors or your prescription drugs, and you have a marketplace policy, now might be the opportunity for you to go and look at what is available to you. And even if you looked in the fall and you didn't qualify for financial assistance, or it wasn't very much, it may still be worth your time to do that again now because there are new rules. Now, outside of a pandemic, there are some opportunities if people experience a loss of coverage to pick up a new plan. And these are called special enrollment periods. And thanks to the Affordable Care Act, we have more options as consumers than we ever have before. And I know that a lot of people are experiencing job loss due to the pandemic, but maybe also due to a new diagnosis. And so in those situations, COBRA might be a great option. And the reason I'm specifically bringing that up right now is that right now, for the next 6 months, people can have their COBRA premiums paid for free. And again, we have more information about all of that on our chart of state laws. When we are in a position where we're trying to compare plans, how do we go about doing that? So this analysis that I'm about to give you works whether you are trying to compare to marketplace plans, whether you're trying to compare a marketplace plan to an employer plan, maybe you're trying to compare two employer plans, or maybe you're even trying to compare to Medicare plans. Same analysis, here we go. Here are 3 different policies you might be eligible for. There is a bronze plan with a $173 monthly premium, a silver plan with a $271 monthly premium, and a platinum plan with almost a $400 a month monthly premium. So how do we figure out which policy is going to be most affordable to us, assuming we're going to hit the out-of-pocket maximum, which is a pretty safe assumption when we're talking about cancer treatment. Can we tell just by looking at this? I can't. I actually have to do the math. And here's how you do that math. You take that monthly premium and you multiply it by 12, because that's how much you're going to pay in premiums for the whole year. And then you add the out-of-pocket maximum to that. And when you do that, you will see what it is going to cost you at the end of the year. And even though that platinum plan has almost a $400 a month premium, you can see that it ends up being almost over $2,000 cheaper come the end of the year. So sometimes we get sticker shock just looking at that monthly premium, but if we don't do the math, we might end up with an inferior policy that we're going to pay more for, which is obviously not ideal. But certainly the cost is only part of the equation. We also have to make sure that we are picking plans that include all of the doctors and labs and pharmacies and hospitals that we are using. Because remember, that out-of-pocket maximum only applies to in-network services. It's also really valuable to make sure that any prescription drugs you're taking right now, or that your healthcare team can anticipate you might be taking for the next year, is included in that drug formulary. So not always possible, but having a conversation with your healthcare team about what do you expect I might be needing for the next year can be really valuable. Now, switching gears slightly, I mentioned that the other major contributing factor to financial toxicity after a cancer diagnosis are employment changes. And there are situations, especially when we're talking about metastatic diagnoses, where people face assumptions. So it's assumptions of their own that I can't possibly work and there's nothing that can help me. There's assumptions from their providers that they can't work and that there's nothing that can help them. And then there's the assumptions from their employers sometimes too. But the reality is there are many tools rooted in the law to help individuals work through treatment, take time off, or return to work after a period of treatment. And so I just want to empower those of you who are thinking about, is it possible for me to work, that there may be tools to help you do that. But of course, that's not always possible. And so if you do have to take extended periods of time off, how do you cope with that loss of income? One way to do that is through disability insurance. And disability insurance is an insurance policy that is designed to make up for the lost income because you can no longer work. So every policy is slightly different, and they're only going to cover a percentage of your monthly income. There are several sources of disability insurance, including private and state, but there's also federal disability insurance programs that are long-term. And of course, I'm here to answer questions and will stay on through the end of the presentation. But again, please know that this doesn't have to be the last opportunity for you to access this legal information. And on our website, we have a host of resources divided up by category. I also just wanted to mention that we have some virtual educational programming occurring as well. So if you want to learn more about these legal topics, you have the opportunity to do so. So thank you so much for inviting me to be here. I'm delighted to be here, and I look forward to your questions.
So good afternoon, and thank you to LBBC. I'm Shanta Chambers, so glad to be spending part of my Saturday with you. And I really want to reinforce one thing that Monica touched on, and that is the simple fact that you do not have to pursue these things alone. You're not in this alone. So you have organizations like LBBC, Triage Cancer, as well as Patient Advocate Foundation, which are all here for you to help you along in the process as you try to access resources to support you in your cancer care. So I want to just talk a little bit about some of those resources that are available through Patient Advocate Foundation. So this year we're celebrating our 25th anniversary. And a couple of years ago, we served our 1 million patient. You know, I was about to say we had the pleasure of serving our 1 million patient. However, that was actually a bittersweet moment for us. So as an organization that's really at the nexus of access and affordability, we realized that yes, we've served 1 million patients and their families and caregivers. However, we also know that there are so many other individuals out there that unfortunately we were not able to reach or not able to connect with us and support. So that really becomes the wing beneath our wings to really help us each day as we continue to work on behalf of patients who are trying to access care and experiencing barriers to those care, whether they be regarding access or affordability. And so as the bedrock of who we are as an organization, we always want to make sure that we're patient-centric and bringing to the forefront those resources that help to meet patient needs. And so here's our CEO, Alan Bosch, and we realize, you know, for us, it is the intersection of not just those things that transpire within the four walls of the healthcare system, but it's also those other social needs, those other social need gaps that are identified. And those could be things such as transportation or housing or utility and the resources that many of us allocate to that. But when we are living with a life-threatening, chronic, or long-going condition, oftentimes we're having to divert resources from those things that are just our basic needs so that we can be able to adhere to our cancer care, any type of care that's recommended for us. And so as an organization, we understand that. And we stand with you in really helping to identify resources to also address some of those social need gaps as they present. So who we are. So PAF, as I mentioned, we are a 25-year-old organization, and we were founded around this principle of case management. And that is really around aligning someone with one of our case managers side by side to help them identify what are some of those barriers that they are experiencing, whether they be financial or, as Monica pointed out, if they may be insured. We hear a lot of patients that, as Monica pointed out, when ACA was first implemented, a lot of people who were living with chronic and complex health conditions, they actually chose those bronze plans. And they chose those plans because, as she pointed out, the monthly premiums were much lower. However, unfortunately, so many of those individuals later learned that those plans were inferior in terms of being able to respond to their very specific and unique needs. And so where we are as an organization, we are now in a position to really help people understand, as Monica pointed out, yes, it look like this enormous monthly premium for platinum, but at the end of the day, it's really about making sure that you're going to have a plan that really meets your needs. And so as an organization, as Monica pointed out, healthcare is very complex, and health insurance is even more complex. So we've taken this case management posture that allows us to assign a case manager to every single individual that contacts us, that becomes the person that really walks alongside that patient or their caregiver to really help peel back the onion of what some of those barriers are that they may be experiencing. And so we work with you as a team in a very collaborative fashion to help bring resolution to some of those challenges as they are identified. And also through our case management platform, we really use those as teachable moments because, as Monica pointed out, health insurance, healthcare is very complex. And so where possible, we like to engage with the person who's living with whatever condition or their caregiver as we're reaching out to, whether it be Medicaid, Medicare, or an insurance provider, or any other resource that we may be reaching out to on behalf of that patient, so that they can begin to hear the words that are being used, hear how our case managers are responding to specific questions. So if they ever find themselves in the same situation again, we hope that this way of interfacing with us allows them to have the right words or know the words to say when they're trying to seek assistance and resources on their own. As it says here, our case management services are available to any U.S. citizen, and they must be receiving treatment in a U.S. facility, and they can be diagnosed or being screened for any life-threatening chronic illness or any kind of life-threatening, or chronic condition. The case management support is available at no cost at all, and that doesn't matter if someone calls us one time or if they call us 100 times. We are here to be a resource, and we know that financial resources are so prohibitive to access for so many things, and we wanted to make sure that that would never be a factor for those coming to us for support. And so this is just to give you an idea when we talk about what our case managers address. What I'm showing here are the top 10 case management issues. And as you can see, they vary. They vary from everything to nutrition and food assistance, all the way to assistance with utility and other things of that nature. And so this is actually reflective of the very tangible and very real situations that people actually come to us with every single day. And the block on the right really shows you the top resolutions. So when people come to us and they have issues around food insecurity, what we'll do is work to locate either discount food assistance programs, or even if they're vouchers for food services. If people are finding themselves in a situation where they need mortgage relief, we're working to identify that mortgage payment relief. And the biggest thing that people often come to us for is because they're experiencing financial difficulties in trying to pay for some of their pharmacologic therapies, or even those copays that Monica pointed out in her presentation. The uniqueness around how we actually approach this work is there is no one size fit all. So we don't think that we don't do this by one approach and apply that to every single individual. The only thing that's standardized about the process is really the intake procedures. And from there, our case management is responsive to the unique needs that is identified by the person that our case manager is on the phone with. And so we're going to do everything that we can do, not only to respond to the immediate issue that may have prompted you to contact us now, but also to think down the road a little bit more about some potential hurdles that individuals may encounter. So we have a host of different financial support programs, and these financial aid programs are exactly that. They are small grants that we actually make directly to patients, and they address those non-medical. So most oftentimes these small grants apply to things such as transportation, housing, short-term lodging, or utility and nutrition needs. So again, it's when someone contacts us and they've identified some of these needs, and our case manager, again, is going to look to see what resources are out there. And one of the things that's very important to point out is that our case management team is not in the business of saying, hey, here's a list of all the potential resources that you can call. It is our case managers that are actually making these calls on behalf of the person living with the condition and their caregiver, because we really want you, as a person living with, whether it be metastatic breast cancer or any other chronic condition, we want you to really be able to focus on your health and your treatment, and not have to spend so much time standing in a queue or making calls after calls and having to complete forms. When we say we're there beside you, we really mean that in the core of how we do our business. One critical program, we are one of only a few programs that offers a co-pay assistance program. So we do have an OIG opinion to operate a co-pay assistance program, and it's exactly that. It is a program that actually provides co-pay relief to individuals that are living with very specific diagnosis. I'm going to show you in an upcoming slide how you actually can go to that program and how you actually can apply, but I wanted to share with you some of the criteria for that co-pay program. In order for individuals to be eligible, they have to have a household income of 400% federal poverty. They must be living with the qualifying diagnosis for which the fund they are applying for. So for example, if we have a metastatic breast cancer copay fund, then the individual applying to that fund, of course, would need to have metastatic breast cancer. The person also has to have some form of insurance. It can be Medicaid, it can be Medicare, it can be private. If by chance someone first interfaces with us is through our copay program and it is identified that they don't have insurance, what will happen is our copay team will actually link that individual to our case management team so that they can work with them on identifying and enrolling in a health insurance plan. Also, this program is not therapy specific, so it does not matter what your therapy is. The qualifiers are around income and having the qualifying diagnosis as well as the insurance coverage. So this is just to give you a little bit of detail about the program. This is truly first come, first serve, and we actually award these on a 12-month period. So if you apply this year, say on April 17th, and if next year we have the same fund open around the same time, you can also come back and apply again. And through our copay program, we actually also do a 6-month look back. So once someone is actually approved for the program, our copay team would actually work with them and look back 6 months. And so if you have some expenses that have maybe been sitting that you haven't been able to afford, then if you are eligible or approved for our copay program, the team will actually look back 6 months. And also at the end of your award, as I mentioned, all of these are a 12-month award, but you do have a 2-month grace period to submit any final expenditures. We do ask that when someone is actually approved for our copay program, because we do earmark the full value, that we want to make sure that individuals are definitely utilizing. So we do have a utilization requirement as a part of that. And again, you can reapply every year at the end of your 12 month. There is no limitation to your ability to reapply. So this is actually just a screenshot of what the Copay website looks like. I tell individuals, we open and we close funds all day, every day, and funds open and close really quickly. It only takes you about 7 minutes to actually do the online application. And honestly, if someone was to go to this copay.org, if we do have a fund open for which you would be potentially disease or condition eligible, you could start your application. And by the time we finish this workshop this afternoon, you would actually know if you are approved. And once you are approved, the relationship becomes between us and your actually pharmacy of choice. So we handle on the back end all of the administrative pieces, unless we're actually doing a 6-month look back and we may actually need information from you. So again, it's a pretty simple process. There's a portal for patients to actually apply on their own. Your healthcare provider could actually apply on your behalf. And we actually added a portal for pharmacists, because we heard from the pharmacy community that oftentimes it is at the point when someone is coming to pick up their prescription that sticker shock happens. And so that is why it was so important for us to add a pharmacy portal, so that as pharmacists are encountering patients that are having difficulties paying for their therapies, they can make an application on behalf of that patient for our copay program as well. One of the other things that I really want to share with you, and if you take nothing else away from this talk today, I want to make sure that I share this resource with you. This is what we call our National Financial Resource Directory, and it is actually housed on our patientadvocate.org site under Explore Our Resources. And I want to share this with you because what we've actually done is we've cataloged in a digital online directory and a mass of resources from across the country. We've built this directory based upon what we've heard from patients in terms of what are some of the social needs or other financial gaps that they were experiencing. So every single resource that we as an organization have actually developed, it is in response to something that has been identified by our patients. And because of that, we're constantly kind of updating, because we always want to make sure that we're in real time with being able to provide patients and caregivers and their family members with the information that they need so that they can begin to respond to the needs of those in which they care for. So this particular screen reflects their 2 tabs. One is for those individuals who are uninsured, and you can search and it'll populate all of those resources available to persons who are uninsured. And the green tab, of course, is for those who are underinsured. You actually would select, you see there are 4 tabs. One is around age, your residential state, your medical diagnosis for which you want to search for resources for, and then the assistant type needed. So under assistant type needed, there are 32 categories. Again, these 32 categories are built from the various types of issues that individuals have come to us. And so we use that to really begin to catalog these resources under those more broader headings. For one of the things that we really want to talk about, one of the things, let me back up, one of the things we also did, we did an on-demand video to really talk you through how you can actually use the National Financial Resource Directory. So don't feel like even if you want to access it, don't feel like you're alone. We have an on-demand video that walks you through how you can actually access the directory, how you can actually populate resources. And it will give you resources on a variety of different things. And these are resources that you can either call, or if you're looking on behalf of someone, there's an email feature where you can email these resources directly to them. And we did this because we realized that not everyone may be at a point to where they're ready to pick up the phone and seek assistance. So we wanted to make sure that the same resources that our case managers have access to, we wanted to make sure that everyone has access to this and they can access it in a way that is most comfortable for them. And so I want to turn our attention that, as I said, we're a very patient-centered organization. And as a result, when we begin to learn more and hear more around the very specific needs of those living with metastatic breast cancer, we wanted to make sure that we built out specific resources for those living with metastatic breast cancer. So not only do we have the National Financial Resources in a very global sense, we actually have a sub-resource specifically for breast cancer resources that we call our Breast Cancer Resource Directory. Here on this slide, you see both in English and Spanish, all of the resources that we actually have available for those that are living with metastatic breast cancer. So as I mentioned, we do have a subdirectory within our National Financial Resource Directory specifically for breast cancer. The purple tab is specifically for those resources, for those looking for resources for those living with breast cancer, but we also have a specific tab in blue for those that are living with metastatic breast cancer. This allows you to search solely for those resources that are available to support those living with metastatic breast cancer. This resource can also be accessed from our patientadvocate.org website. And this is just another screenshot so that you can clearly see. When you click on purple, the entire screen will be purple. That will tell you that you are searching for breast cancer resources. When you click on blue, as you see here for the age range, residential state, and assistance needed, you will see that everything will turn blue. One of the things that's different here, you may recall that on the National Financial Resource Directory, it asks for condition. Well, because we know that this resource is specifically for those with metastatic breast cancer, there is no need for you to select that here. All you have to do is select the actual assistance for which you're searching for resources. Also, we have a wealth of just educational resources in our library. One of the things that I really wanted to point out here is oftentimes one of the things we've learned from our patients, especially those who are insured, is that they often didn't know that they actually have a right to appeal an insurance decision. And so because of that, we actually did a webinar around health insurance denials and appeals. Don't take no for an answer. And what it does, it really describes for someone how to actually go about the appeal process. And so it walks you through what an appeal is, how do you actually go about initiating that process. But not only do we have that as a part of our resource directory, that is probably one of the biggest things that our case management team does a lot of work with and on behalf of our patients, really working with them on the appeal process. And our case managers are there to help you do everything up to actually submission of your appeal. So this is just a list of some of those learning and education series. Again, this is all built from what we've heard from patients. And one of the biggest pieces was around insurance appeals and not knowing how to go about that process. So this entire case management education series is designed to do that. It is really designed to take you through the entire process, soup to nuts, from A to Z, of actually how you would actually go about the appeal process. And that doesn't matter if it's an insurance, private insurance, or if you also have a Medicare or Medicaid related appeal as well. These are just some other resources. Monica touched a lot on the whole health insurance piece. We also have a guide for health insurance marketplace, as well as Choose Wisely. So even tips for Medicare enrollment, because even with the onset of Medicare Advantage, a lot of our individuals who are Medicare eligible, there was just some confusion around what do we mean when we say a Medicare Advantage plan? What does that look like? And what should I consider as I'm choosing those plans? So these are just some additional resources for you. And so I kind of wrap up here. So this is our contact information for both our Patient Advocate Foundation, of course, a direct number for our Copay program. All of the resources that I've shared with you are available to you at no cost at all, whether it's our case management program or a Copay. So if anyone ever charges you on behalf of PAF, just know that is not us. That is not who we are. We are an organization that will be on the front line to make sure that financing and getting access to these types of resources should never be prohibited by one's ability or inability to pay for them. And that is why we as an organization remain committed to making sure that all of the services and supports that we provide are available to those either caregivers, patients, living chronic conditions, or healthcare providers who are actually acting on behalf, never have to pay for our services and support. So realize you are not here. And you're not in this alone, and PAF stands ready to support you.
Thank you, Monica and Shanta, for those great presentations. Before we get on with the Q&A, and please put your questions in the Q&A so we can get your questions answered. I want to let you know about the LBBC fund. We all know that breast cancer is very expensive, and we've been especially hard hit during the COVID times with increased financial hardship. Living Beyond Breast Cancer has a one-time grant to help decrease the financial burden. And if you need any more information about that, please go to lbbc.org. So that's another resource for you. So anyway, I'm gonna check the questions that are in the Q&A right now, and maybe they'll spawn some other questions. And I don't know who this would be for. Maybe this might be for Monica, but I'm sure Shanta can weigh in too. Is a chemotherapy drug considered in the prescription drug part of Medicare Advantage, or is chemotherapy drug in a different category?
So the answer, as so many of my answers typically start, is it depends. So it depends on how the chemotherapy is being administered. If it's IV chemotherapy, then it's actually going to be covered under a medical benefit. So in original Medicare, that's going to be under Part B, or in Medicare Advantage, it's going to be under the umbrella of that Advantage Managed Care program. If it's an oral chemotherapy, then it will be considered a prescription drug, and it would be covered under Part D. Or if you have an Advantage plan that has prescription drug coverage, it would probably be covered under that. But it so much depends on the chemotherapy, how it's administered, and the exact plan. But certainly you can always reach out to Triage Cancer with specifics, and we can try to give you a more targeted answer.
Okay. Shanta, did you want to add anything to that? Is that, we're good with that?
You can never find the unmute button when you need to. No, I didn't have anything to add to that one. Monica captured it.
Okay. Thank you, Monica. All right. We've got, if it's too late to select an insurance policy and you've lost your job, what do you suggest to do as the bills pile up?
I would say it's not too late. So as I mentioned, we have an unprecedented opportunity right now because President Biden reopened the health insurance marketplaces. And so those are private insurance policies sold by private insurance companies like Humana or Blue Cross Blue Shield or whatever it happens to be in your state. And the advantage to buying through the marketplace is that A, you can pick it up right now, and B, there might be financial assistance for you to both pay for the monthly premiums, but also to pay for the copays and the deductibles and the coinsurance. So I would say the immediate thing you need to do when you click off of this conference is head to healthcare.gov, answer a few pretty simple questions, and see what's available to you right now. Now, that's not going to solve the problem for what you've already incurred. And so you are still going to have to deal with that piece of it and communicate and negotiate with your providers. But very often, once you're able to communicate with your providers, they're willing to work with you and do I've seen a whole host of things, setting up payment plans, cash payments, even sometimes forgiving the debt. So sort of two-step process. One, sign up for insurance so that you're protected moving forward, and then communicate with your providers to deal with anything that you've incurred thus far.
And Lori, I actually would add to that. And I would say this is probably a place where an organization like PAF can be extremely helpful. Because as you are beginning to look at applications, we can really work with you, walk through with you the application process, as well as our team is well versed in identifying if there are those premium subsidies that Monica just touched on, if they are actually out there, and actually how you actually acquire those premium subsidies, but also work with a plan around those bills that you say are already piling up. I think when we look back at 2020, that we were able to help our patients mitigate about $22 million in actual medical related debt. And that is because of those things that Monica just talked about. You know, oftentimes we get these bills and we just shove them in the drawer. I've been very guilty of that because it can be so overwhelming. But sometimes it's overwhelming because we're trying to do it in the midst of everything else that we're trying to do. And so I would just recommend that you don't try to do this alone. You walked away, you're going away today with some invaluable resources. And I encourage you to reach out to PAF, reach out to, and let us help you as you try to navigate this whole insurance place. And as you try to find some solution to some of these other financial obligations that have already happened.
Hey, Lori, can I just add one more thing? And I'm so sorry. In addition to everything amazing that Shanta just said, I agree wholeheartedly, but I just thought of something else in that because of COVID, we have another opportunity potentially, depending on how long ago it was that you lost your employer-sponsored insurance, you might actually still be eligible to sign up for COBRA and have those monthly premiums free for the next now 5 months. Mm-hmm. And again, that's because of COVID, but you don't actually have to be impacted by COVID to take advantage of these programs. So I'm sorry that I just thought about that, but this is stuff is changing so quickly. Absolutely. Which is why that it's so important, and it's, you know, to your benefit to keep in touch with organizations like PAF and Triage Cancer, because we're trying to stay on top of the changes as they're happening and then share them with all of you so that you all can benefit to the extent possible.
Oh, thank you. Thank you, Monica. Thank you, Shanta. That was a great answer. I just wanted to make sure that the participants are looking at the chat because some great resources are showing up in the chat. Some great links, quick guide to managing medical bills. There's a link for the special enrollment period. So they could check that. I think that would be great also. All right. Is it too late? No, sorry. Please explain the difference between the copay relief and the copay assistance programs.
So copay relief is actually an initiative of Patient Advocate Foundation. And as a part of it, we actually administer financial resources to help individuals offset their pharmacologic costs. Now, many pharmacy companies, many industry companies also offer what they have copay assistance programs. And those are actual programs that they have where those persons who are on their specific therapies can either get their therapies at no cost or significantly reduced costs. Now, for some of those copay assistance programs, there are some populations that are not eligible. Potentially for some of them, persons who are covered by Medicare, by if I recall correctly, are not eligible for some of those copay assistance programs. So that's one distinction. So I want you to think about copay relief, really only think about copay relief that is the actual program within PAF. And for us, unlike the copay assistance programs that are linked to specific therapies, our program, our copay relief program, provides financial support irregardless of the therapy, but it is actually driven by the actual diagnosis. And if that does not answer the question, please ask for more clarification.
Great. All right, we have, is the COBRA assistance only for people who have lost employment due to COVID? For example, the job laid you off or reduced their hours due to COVID, but not due to cancer disability.
No, and that's actually what I was trying to say before, in that people can take advantage of these programs that were born out of COVID, but they don't have to be impacted by COVID. The one qualification is that the reason that you're COBRA eligible has to be that you've either lost your job or that your hours have been reduced so that you're no longer eligible at your job for benefits. So if somebody has lost their job, whatever the reason, except if they decide to leave, so that's a difference. But if they've involuntarily lost their job or had their hours reduced, they can benefit from that free COBRA premium for the 6 months. Now, you work for employee. I'm sorry if my internet is wobbling. Hopefully you can still hear me. You do have to work for an employer with 20 or more employees to be eligible for the federal COBRA, but there are also state COBRA statutes that cover smaller employers. So valuable to look at what's available to you in your state. And at triagecancer.org, we have a chart of state laws that gives you the details of all the state COBRA statutes as well. And we've learned that this premium assistance counts for state COBRA as well. So it really is an incredible benefit for folks that are COBRA eligible.
Absolutely. Could you please expand the eligibility for the free COBRA? How long after they lost their job can they apply?
So in normal circumstances, you have 60 days from your qualifying event, which in this case would be job loss, to elect COBRA. But again, due to the pandemic last year, they extended that time period and it is still ongoing. And so there are some nuances here that might be too detailed for today, but we have a blog that details all of these topics. But basically what I would say to you is if you have lost your job in the last year and would have been COBRA or state COBRA eligible and think that might have been a good option for you, call your job and get some more information, and certainly reach out to Triage Cancer or PAF to get more details about your specific situation. Don't just assume that it's too late, because it might not be.
Excellent. All
And
right.
don't assume that the answer is going to be no, because it may not be that either.
You just told us that oral cancer drugs are Part D. This is a big money problem because more and more cancer drugs are oral and the copays are so big. I don't think legislators understand this. I wonder if any organizations like ACS or AARP are lobbying for cancer drugs to be covered.
You want to start, Shanta?
I would just simply say I can tell you that yes, that is on the agenda for ACS CAN, and so that is something that they are looking at. And I think this is actually an issue that not only just these organizations are looking at as well. Patient Advocate Foundation, we also have our policy side, which is National Patient Advocate Foundation, and financial toxicity is one of our focus pillars as well. And so we have this on our radar because innovation is coming at an extremely high price, and unfortunately is also furthering disparities around access. And so for those reasons and a lot more, we as an organization have this on our radar along with our colleagues at ACSCAN and some of the other patient advocacy groups as well.
Yeah, just to piggyback, I mean, you're 100% correct. It is a big problem. And frankly, the way that Part D is set up is a problem for individuals with serious medical conditions. And there aren't ways to protect yourself from the out-of-pocket costs the way there are with Part A and Part B. And so it is certainly a challenge. A lot of people don't realize that Part D is actually relatively new. It was only passed into law in 2003 and effective in 2006. So compared to the other pieces of Medicare, it's a baby. And it certainly needs some improvement. There are advocacy efforts, certainly within the cancer community, but even outside of the cancer community to address that. And I would encourage you, if this is something that you feel strongly about, to contact your elected officials and explain to them from a human perspective why changing these rules is important and the kinds of people that it is impacting, because that's what they need to understand. And certainly, you know, I'm a big proponent of legislative advocacy coming from the Hill, but you don't have to be a lawyer to be a good advocate. In fact, most of the great advocates I know are not lawyers. So I certainly encourage you to have your voice be heard, and I'm here to help you do that in whatever way I can.
The best advocates I know are not lawyers.
True story.
Because I think what's so important about that question is that I don't think legislators understand this. And it's because they don't understand the impact to the constituents for which they represent. So here's an opportunity for you to really help them understand by as Monica stated, reaching out. Your experience, your story is powerful, and your experience and your story helps people understand that there are real people that are being impacted by these types of financial decisions. And guess what, Legislator X? I'm somebody in your community that is directly impacted by this.
Very good advice. Thank you. I think we probably got time for one more quick question. Are metastatic breast cancer patients considered in treatment? Wouldn't that make them eligible for the breast and cervical cancer prevention and treatment program?
So can we get a little clarity on which breast and cervical cancer prevention and treatment program that they are referring to? So if they don't mind providing a little clarity to that. And while we're getting clarity, I'll respond to the other question. So someone also asked if prescriptions are being filled at Kaiser and House, would the copay program still be eligible? Absolutely. So it's irregardless of where you actually have your prescription filled, whether it's Walgreens, Kaiser, CVS, or local pharmacy. It is really about meeting the income requirement, the insurance requirement, and the condition requirement. It does not matter where you're currently having your prescriptions filled. Once you apply, and if you are approved of the program, you can you're provided almost with like a financial card for less of a better description that you would actually share with the pharmacist that actually fulfills your pharmacy. So it does not matter where you actually get your prescription filled.
Thank you. I think we're going to have to cut off right now. Thank you for joining us. Thank you, Monica. Thank you, Shanta. It was a great presentation. We had got such good information. Please join us from 3:15 to 4:15 for the next keynote address, which is addressing palliative care. That'll be very interesting, and it's something that all metastatic patients really need. So thank you everybody for attending, and we hope to see you around the rest of today and tomorrow.